To teaching on Tuesday, I guess. Today we're going to be doing a little bit of science. So everybody who's on Instagram, jump over to Facebook Live. I'm going to be doing a talk over on Facebook Live. So everybody who's on Instagram, jump over to Facebook Live. I'm going to be doing a talk on hysteroscopy, pelvic masses. I'm going to be talking about thyroid disease. So just giving you a little bit of an update, 2021, on some things we know. So all you folks that are on CNY Instagram, jump over to CNY Facebook or CNY YouTube, and we'll be doing a little discussion. And then once we do the discussion, we'll jump over to back to questions and answers. We'll talk for about 30 minutes. I'm Dr. Magarelli, CNY Fertility, Colorado, bringing you my live from Colorado Tuesday talks, a little bit of science, a little bit of questions, a lot of answers. Anybody up on the, we've got about 9 people jumping on the Facebook. All you folks who are on Instagram, jump over to Facebook Live. That'll help you guys a lot. So you'll get to see the pictures that I'm going to be presenting. We're going to talk for about 20 minutes, and then we'll jump back to a Q&A, and hello, love the kisses. Hello, everybody. Hi, Emily, Travis, Butterfly, Unicorn, and Sunshine. Jump over to Facebook Live. We're going to be doing a lecture over there. Please say hi on Facebook. I'm not seeing any comments yet on Facebook. I got a kissy. Great. Someone say hi. I'll say hi first on the Facebook side. See if that's running. Yep, it's working. Okay. So I've shot a hi. There's Tiffany. Hello, Tiffany. Thank you for saying hi. Misty Badass, jump over to Facebook Live. We're going to be doing all of our talk for the first 30 minutes is going to be on Facebook Live. Tamira Luby, welcome. JC Bedokovich, hello. All those people who are on Instagram now, please jump over to Facebook Live and YouTube. CNY Facebook, I'm going to be doing a lecture. Hey, Fiona, Antoinette, JC, good to see you. Thank you for joining us. All you people who are on Instagram, jump over to Facebook, CNY on Facebook and CNY YouTube. We're going to be doing a lecture. I do a lecture every other week. This way you can see the slides, you can see the details. There's going to be some interesting stuff about testing, about the thyroid, about pelvic masses. So all of you folks on Instagram, jump over to Facebook Live. Hey, Jamie Winston, hola, good to see you. Thank you for joining us. All you folks who are on Instagram, jump over to Facebook Live. This is Dr. Magarelli, CNY Fertility. Nisa, These Wing Scorpio, jump over to Facebook Live. Kate Fisher Quinn, jump over to Facebook Live, because that's where we're going to be talking about hysteroscopy, hysterosonograms, hysterosalpingograms, the dye studies. We're going to be talking about thyroid, how to test for the thyroid, why we test for the thyroid. We're going to talk about masses in the pelvis, what keeps you from starting an IVF cycle. So all you folks on Instagram, looks like we're down to 0. Kara, jump over to Facebook Live. Kara 1513, jump over to Facebook Live. Savannah, jump over to Facebook Live. And okay, so I'm going to jump over to Facebook Live. All you folks who are on Instagram, please jump over to Facebook Live, because that's where we're going to be talking. So what are we going to talk about today? Well, we're going to talk about hysteroscopy and the evaluation of the uterus. Now here you see an image, and on the image you see, I call it the pap smear with a telescope. Basically, it's a telescope that you can look inside the uterus, which allows us to do what's called the gold standard of uterine evaluation. Now, most of you have done what you call the hysterosalpingogram, HSG, tubal dye study, and what that is it's an X-ray of the uterine anatomy. All you can see is a cavity. You cannot see the muscle. You cannot see the fallopian tubes. You cannot see the ovaries. You just see the outline or shadow of the uterus, and that's from the iodine dye that's picked up by the X-ray, and it's developed to come out white, typically, is how they do it. You can reverse it. And here you see the beautifully shaped uterus. Both fallopian tubes are open, and you can see that the fluid is spilling out. So this would be a normal hysterosalpingogram. All you folks who are on Instagram, jump over to Facebook Live because I'm going to be doing a lecture for about 20 minutes here, and then I'll come back to you guys' questions in a second. The other thing people get done is called a hysterosonogram. Now that's different. Instead of using an iodine dye and an X-ray, we use an ultrasound machine. As you can see, with the ultrasound machine, you can see the cavity, but here the cavities, when it's a fluid, is black, whereas when it's a fluid, it's white in the HSG. And you could see that you could also see the muscle. This is the uterine muscle. So this is sort of a transverse view of the uterus itself. So you can see the cavity, and here's a normal cavity, but here you can see a beautiful picture of a polyp. So again, with a hysterosonogram, you could clearly see the polyp, not so much with the hysterosalpingogram, but in reality, the hysteroscopy can actually see the polyp much more clearly. So the HSG, or the dye study, is an X-ray. It shows the uterus and the fallopian tubes and a spill of the dye into the pelvic cavity. This is great basic evaluation if you're doing like an IUI or you're trying to get intercourse to achieve a pregnancy and you're going to rule out either a tubal blockage or a uterine problem. The HSG is pretty easy to get, and it's kind of ubiquitous, and everybody thinks that they have to do that. You don't have to do that if you're doing an IVF cycle. The cons for doing this, well, if you're allergic to seafood, you can't take the iodine. If you're allergic to iodine, of course, you can't take the HSG, and it's only about 75% accurate. So it's not ideal for like an IVF cycle. The second one I mentioned was the hysterosonogram, and that's where we actually use fluid, not iodine, but fluid, so saline, salt water, to basically look at the displacement of the fluid inside the cavity, and the ultrasound picks it up as black in color. And that can tell the lining of the cavity. It's not great for telling you if your tubes are open. It gives you an idea. So it's kind of a poor man's version of an HSG. Now the hysteroscope, I call it a pap smear with a telescope. And all you folks who are on Instagram, please jump over to Facebook Live because I'm doing a lecture for about a half an hour. So all you folks who are on Instagram, jump over to Facebook Live and YouTube Live, CNY Fertility Live. And you'll be seeing me over there talking with. You could see the slideshow. So hysteroscopy, and this is again going back. This is hysterosalpingogram, hysterosonogram, hysteroscopy. With hysteroscopy, you can see the uterus only, but you can actually see every aspect of the uterus. So it's really the gold standard or the best way for us to look at the uterus for IVF cycles. And we tend to do them under anesthesia. You don't have to. And there, of course, are risks like bleeding, infection, trauma, etc. Those are some of the downsides. They're very small. So here's another nice picture of the hysteroscope showing a polyp and showing the camera, but also showing a little scissor, which we can use to clip off the polyp from inside the uterine cavity there. Let me see something here. I'm not seeing any people coming on the, let's see. Okay. All right. So when the best time for you guys to get the hysteroscopy done is between days 7 and 11 of the cycle. Or if you're on birth control pills, you can pretty much do it at any time. It's a very nice way to look for pathology inside the uterus that can cause you to miscarry. So I'm a very strong believer that you should get a diagnostic hysteroscopy for all IVF cycles. That's kind of the gold standard. It's worth doing. Some folks can't get it, and so you have to deal with the hysterosonogram or hysterosalpingogram. Complication rates are less than 1%, so it's a very low complication rate. You shouldn't do it if you have an active pelvic infection or sexually transmitted disease, especially herpes simplex virus. So you wait until you cure that. There are risks like air embolism, etc., but there's a way to mitigate that, and we have techniques to do that. You don't necessarily need antibiotics, but for fertility patients, I tend to put them on antibiotics just to be sure. And there are ways to soften the cervix if there's a problem with getting inside the cervix. Let's see here. Okay. So one of the biggest worries when you do hysteroscopy, of course, is perforation. We use a flexible scope. It's a plastic type flexible snake-like scope. So the risk of that is very, very small. Cervical stenosis, where we can't get the scope inside. So again, we have dilators to help with that. And then, of course, each person's anatomy is unique. In the old days, when we use a certain type of fluid, you could get a fluid overload. Now, we don't see that now. The technique usually lasts about 3 to 5 minutes. It doesn't take much more than that. And we usually do it right in the office, again, with or without anesthesia. Most of our folks like anesthesia, though. There are various other complications associated with doing hysteroscopy, like shortness. If you feel after the procedure any shortness of breath, chest pain, it could be that there's an air or gas embolism. Again, extraordinarily low chance for that to happen. So what do? We purge the air out of the tubing, we minimize repetitive insertion, go back and forth, and we limit the pressure. And then Durant's maneuver to relieve that embolism is to place the person on the left side in a Trendelenburg head down position. And that seems to do very helpful for that. Hemorrhage, of course, any kind of procedure has that as a risk. And then just the vasovagal response, like a fainting, is associated with it. Again, though, much less than 1% chance. So again, these are very short little mini lectures. I just wanted to reintroduce you to the uterine evaluation. So if you're going to be doing IUIs or trying sex to achieve a pregnancy, then you really want to do a hysterosalpingogram or a dye study. If you're doing IVF, hysteroscopy is considered the gold standard. Hysterosonogram, you can use it if you can't get a hysteroscopy. And if you can't get either of those, then a hysterosalpingogram is good enough. Watch out for allergic responses if you have allergies to seafood or to iodine. And it's about 75% as good as the gold standard hysteroscopy. And then if you're going to do hysteroscopy, just remember, like in all procedure, there's about a 1% chance that there may be a problem associated with the procedure itself. Now, again, CNY, we can do that anywhere at our offices. I think pretty much every office. I know Colorado does, Syracuse does, Albany does. Not 100% sure if Buffalo does it in-house or not. Again, folks, I'm going to do a short lecture. Those who are on Instagram, jump over to Facebook Live or YouTube, because that's where the lecture is. And then I'll jump back to questions and answers here in about 15, 20 minutes. Now, we just talked a little bit about hysteroscopy. Again, I'm going to show you because you guys like this. Here's a hysteroscopy, pap smear with a telescope. Hysterosonogram, we put dye inside, uses an X-ray showing you the uterus and the fallopian tubes. And here you see a hysterosonogram or an HSS, and you'll see the lining here. And I just got word that it's Buffalo. They do it at the local hospital. Thank you very much, Savvy Save 2. By the way, folks, I really appreciate it when you guys have answers for things that I don't know. The idea here is we're sharing information. And again, I want to tell you, I'm in a good mood today. Is that right? Well, I was just going to say, sometimes you may find that I'm not the nicest person, or I'm very stern, or I'm very dogmatic. And I just want to tell you, it's not you. It's usually there's a lot of pressures going on, and I try not to take my stresses into the exam room. I'm human, unfortunately. So I just want to apologize to those where sometimes I may not be the cheeriest guy, but I do love what I do, and I have an amazing team. So forgive me if I sometimes come across as dogmatic. I'm pretty much an egghead. I'm all about the science. I'm not I really believe in the science. So you will definitely get an argument from me if you say something that I don't agree with, mainly because I want you to know what I know. You can make your own decisions, but at least I want to share. Be that as it may. Thank you for asking me if I'm in a good mood. I feel like I'm in a good mood. I hope I'm in a good mood. All right, so that's hysteroscopy, hysterosalpingograms, hysterosonograms. Talked about the risks. Now let's talk about pelvic masses. Now this is a problem a lot of times when folks are trying to start an IVF cycle and they say, oh my God, we have an ovarian cyst. Well, that's considered an adnexal mass. It's considered a mass. And adnexal masses, here's what the adnexa is. So here's the uterus, and the adnexa is the connection between the mesosalpinx, big words, the fallopian tubes, the ovaries are stuck in this, the adnexa. This is the uterus. Here you see uterine masses like a fibroid, but you can actually have fibroids on the ovary. You can have scar tissue. You can have a mass from a hydrosalpinx. Someone asked a question about. Yes, so these masses, we have to first know what they are. Now, sometimes the ovary itself appears to be a mass, and that's really just a PCOS ovary. And in that case, there's nothing to be done. Sometimes there's endometriomas, which is nothing more than an endometriosis, which is what these blebs are, inside the ovary, but they grow very large. Fibroids, like I said, can grow around the ovary. If you have an infection and creates a tubo-ovarian abscess or a hydrosalpinx, you can see this mass here. And again, this is important for women over 35. If there's a mass and it doesn't go away, think cancer first. Now, you don't have cancer, I hope, but the bottom line is you can't ignore the possibility that there may be something cancerous there. So make sure you take care of yourselves, everybody. All those folks are on Instagram. I'm doing a lecture on Facebook Live and on YouTube. So if you want to jump over, you certainly may. And anybody who's on the Facebook Live or YouTube, just every once in a while say hi or something so I know that I haven't lost you all there. Now, how do we look for the disease? Well, basically through an ultrasound. Most of the time, you'll present to us that you're, thank you, Trina, appreciate it, on the Facebook Live side, thank you. Razin, thank you. So 94 to 100% of adnexal torsions are symptomatic. So you're going to feel something like a mass, and it's going to hurt. Here's a beautiful example here of this picture of an ovarian mass. You can see the ovarian tissue is kind of pinkish. The mass is kind of white. In this case, likely a cyst. 88% of the time, these torsions, which is a twisting of these cysts, can cause a lot of docs to remove the ovary. Well, now we know that 88% of the time, simply by untwisting it, even if it appears necrotic, we can save the ovary. So if you're ever in a situation where you're going to the hospital and you have ovarian torsion, please talk to the doc and say, listen, I want to save my ovary. Now, what can predispose you to this torsion or twisting? Well, PCOS is one thing. Tubal ligation that can cause that. History of pain triggered by activity. Nausea, vomiting, or an IVF procedure. When your ovaries do IVF, they can get very large, and those are multicystic ovaries. You trip, you fall, and then you can twist the ovary, and that can cause the blood vessels, the nerves, and everything to twist. And then all of a sudden you get engorgement, and you get a football-sized ovary. The way to treat it is laparoscopically. 77% of the time, all we have to do is take a laparoscope, look inside, see what's there. So, on Erica, what causes most ovarian fluid is just it's an exudate. It's due to osmotic changes associated with protein in your blood. The fluid on the inside of the blood is less concentrated than on the out. Then all the water goes to the out. Well, the out in this case is the peritoneal cavity. Now, ovarian fluid can be blood that can cause this mass, or simply it's a glandular structure. All those who are on Instagram, we're doing a talk on Facebook Live, so jump back, okay? We'll get to questions later. Right now, we're just going to do this lecture. Fascinating facts about torsion of the ovary. It hurts like hell. That's 95% of the time. It's not a cancer. The median largest diameter in this particular studies was about 3 inches. Usually this is a Doppler color flow study, which they do recommend people get to see if there's blood flow inside this mass. You see it's twisted on itself here, and that causes the fluid to accumulate in here. It's like a tourniquet. 70% of the time you see pelvic free fluid. And again, I think that's secretions or excretions. Most common reported sign is this swirling whirlpool sign of blood inside the ovaries. And even when it's necrotic, which means it looks like it's dying, you could still save that ovary about 93 to 100% of the time. So definitely recommend that they do that. So adnexal torsions, in an emergency, it is an emergency. So don't delay if symptomatic. Get to the emergency room. Call our online triage team, but get to the emergency room. The vast majority of these torsions are treatable, and you can save the ovary. They do require surgery to fix usually. Usually it's done with a laparoscopy. We can be seen in ovarian hyperstimulation and also basic IVF ovarian response to therapy. So you can get it simply because your ovaries have become large, you trip, you fall. Restrict pelvic intrusion, so don't get an ultrasound vaginally. You can get abdominal ultrasound, no sex. And of course, no trampoline, skydiving, or gymnastics. That's said tongue-in-cheek. In other words, keep your activity to a minimum so you don't torse the ovary when it's enlarged. And if it's enlarged as big as 10 centimeters, then it's time for you to go for surgery. It is an emergency. We see it rarely. It happens with ovarian hyperstimulation. Certainly can happen with IVF. So it's just something for you guys to kind of be aware of what the words mean. And so, and then of course, the treatment is surgical, and usually, and I mean more than 80 or 90% of the time, you can save the ovary. Okay, the last quick, these are called little vignettes. I'm not doing a full half hour on each topic. I'm just telling you some up-to-date stuff. We have to get board certified every year. We have to read about 30 or 40 papers, and I tend to read each paper, create some ideas to teach. So this is what some of them, which I thought you might be interested in. Another one, another area that you hear about is thyroid disease in pregnancy, but you can also have thyroid disease preventing pregnancy. That really should read in infertility. Thyroid hormone decreases in pregnancy. Maternal thyroid volume increases almost to a goiter sometimes. Biochemical changes associated with it are the total or bound thyroid hormone levels increase. And so what can happen when you're pregnant is you can get an image of these thyroid changes, which are actually not pathological. TSH decreases in early pregnancy during the first 12 weeks, and that's a marker of your thyroid function. And and the reason it decreases is you have an increase in the free thyroxine, which is the kind of thyroid that you take. And after the first trimester, everything turns back to normal. How can you determine what's going on between hyperthyroidism, total binding globulins, hypothyroidism, and low total binding globulins, thyroid binding globulins? We have this little matrix here. You measure the thyroid, the T3 uptake. If you're doing the radioactive study, which we don't do in pregnant ladies, free thyroxine index and TSH, just by looking at this, you can kind of figure out what's going on and what the diagnosis is for these patients. As I mentioned, TSH increases and then free T4 decreases after the 15th week. So in the second trimester, so overt hypothyroidism, if it was first trimester, would be a normal result. So it's if you see in the second trimester, then there's a problem. Because we do see it in the first. Hyperthyroidism pregnancy is frequently inadequately treated and is associated with a greater risk of preeclampsia with severe features. So controlling the hyperthyroidism, nervousness, we'll talk at another time about regular hypothyroidism, but things like lethargy, edema, problems like that, weight gain, these are associated with hypothyroidism. Hyperthyroidism, on the other hand, is where you have jittery, brittle hair, anxious, and that's associated with the preeclampsia. So the easiest thing to do for us, and we do it during the first 10 weeks of pregnancy, and at CNY, we take care of you during that time. And if you are on thyroid medicine, you should have your thyroid levels checked. So what do we measure and how? Well, TSH, which is thyroid stimulating hormone, is easiest to measure. And in the area of infertility, if your TSH is below 2, we consider that somewhat pathologic. So, I'm sorry, is above 2, we consider that somewhat pathologic for fertility. Now, for non-fertility, you can have TSHs as high as 5, and as long as it's within the normal range for females, you're fine. We also measure free T4 or free T3, and these help us diagnose what type of thyroid disease, hypo, hyper. We also measure antibodies, and the reason we measure antibodies is that if you have what's called Hashimoto's thyroiditis, which is an autoimmune disease, that is associated with premature menopause. A lot of our 20 or young 30-year-olds with AMHs in the 0.1 or 0.5 or an AMH of 1, the first thing I think of is Hashimoto's thyroiditis, that there's been an antibody produced, an autoimmune disease, it's a disease against yourself, an immune response against yourself, self being auto. And these antibodies eat, and this is the way I say it, they eat the thyroid for dinner, and they eat the ovary and the follicles and the eggs for dessert. So if you have Hashimoto's thyroiditis, you have a higher risk of premature ovarian failure, low ovarian reserve. All those folks who are on Instagram, jump over to Facebook Live. I'm still finishing up my lecture. It's almost finished here, and then I'll come back to questions. So thyroid antibodies are really important to have measured at least once. You don't have to follow the antibodies, because once you have them, if you have a normal immune system, you're going to have them for life. What you do want to know, though, is even sometimes when you have normal TSH with positive antithyroid antibodies, you may want to start a very low dose of Synthroid or Natrethroid to offset the antibodies. And keep the person euthyroid. The way we treat thyroid disease is with exogenous thyroid medications, Synthroid, levothyroxine, Natrethroid, Armour thyroid, all of these. And the thing about the treatment of the thyroid is the effect takes about 4 to 6 weeks to show up. So you change your medication dose. You have to wait about 4 to 6 weeks on that dose to determine if your hormone level is back to normal. The other thing a lot of people worry about is that when they're on the thyroid hormone, that their TSH is very low. Really, there's no concern with regards to that. So here's some fun facts about thyroid disease in pregnancy. Overt hyperthyroidism at 9 weeks in patients, you use methimazole to treat it. If it's a new onset fever and sore throat, 10 weeks pregnant with overt hyperthyroidism, you can prescribed by propylthiouracil, you're having a response, bad response, stop it, stop the treatment. At 10 weeks gestation, if you have a hyperemesis gravidarum, which means you can't stop throwing up, and no overt sign of hyperthyroidism, poor prognosis are associated with this condition, not the thyroid itself. So that's something outside of the thyroid, but a lot of people think it might be the thyroid. At 36 weeks gestation, third trimester, overt hyperthyroidism again, with fever, tachycardia, altered mental states, fetal heart rate category 2, you can give propylthiouracil to mitigate that. So these are more technical things, but if you have thyroid disease in pregnancy, just refer back to this. Anyway, this is the reason I put this slide. This is the American Board of OBGYNs 2021. These are the articles that I have to read every year, different types, in order to stay board certified, much like Dr. Kills and others. Anyway, so brief review, quick review, because I'm making these short. We talked about the different ways to evaluate the uterus: hysteroscopy, hysterosalpingogram, hysterosonogram. We talked about adnexal torsion, or things that can cause an adnexal torsion, like an adnexal mass, and the risk associated with it. It's a surgical treatment. It's an emergency, but it is fixable. We talked about the thyroid disease and infertility, but mostly in pregnancy, and some of the things that are normal during the pregnancy pathway. And that's pretty much it. Let me see. I'll leave this one up here. And well, actually, I'll jump back to me here. Let me come back to me, and then I'll start answering questions. Okay, so let's see where we're at. So, JC, how often would you recommend having an HSG or hysteroscope if doing multiple IUI cycles or IVF? Once a year is considered the standard for a repeat of your HSG. All of your uterine evaluations should be done within a year of treatment. If you tested negative for thyroid antibodies 10 years ago, do you think you need to be tested again? Absolutely, Andrea. Absolutely. Azuzina, my transfer is next Tuesday. I have a Neupogen wash Saturday. I don't know. Should I do PRP Friday or Monday? The PRP takes a little bit of time to work. We do recommend PRP twice a week. Yeah, and I agree with you. Don't do it 24 hours before. Jamie, I'll be coming to Colorado soon. Yay! Priming with Omnitrope and Serovital for 3 weeks now. Took blood and transvaginal ultrasound last week. 12 follicles on the left, 11 on the right. Everything looked great except the global nurse called and said TSH level is elevated. I have to be between 0.45 and 2.5. With that said, my level is 3.6. I'm now taking 50. Still haven't got my period. I was told I can start the next steps. Well, you need to increase your thyroid hormone to about 75 micrograms, but get one of your docs to write that order, okay? How long does Tiffany, how long does an HCG wash stay in your system? Well, nobody knows that. Nobody has studied that. My guess is at least 24 to 48 hours. What causes cysts to appear on the ovaries? The natural biologic process of ovarian development causes cyst formation. In women, a lot, and they usually come and go. Rosin, does having fibroids at the ovaries means removing them? No. If not removing the ovary, does it affect its ability to produce eggs? Yes. Tirma, is an AMH of 3.5 normal? That is normal. Jalen, what is the ideal size of a follicle to trigger for an IUI? Anything between 18 and 24 millimeters in mean diameter. Okay, guys, on Instagram, I'm back. If you have any questions there, you certainly can ask me on Instagram. Anybody can ask me any questions now. What is the ideal size? Okay, we already covered that. Norma, my lining is thick for FET. What do you recommend if I don't want to get a DNC? Don't try not to get a DNC. Get what we call a progesterone withdrawal, and that is injectable progesterone, 75 milligrams to 100 milligrams to 150, depending on your size. And then this is IM in the muscle, and then you should have a heavy bleed, and then you should be good to go. You're welcome, Jalen. Salmira, what is the ideal TSH level prior to IVF? Below 2.5. Alyssa, when should you get your TSH antibodies and all the other tests done to see if you have Hashimoto's? During the normal evaluation, Alyssa. If you have a normal TSH, you shouldn't even be concerned. Not true. Not true. That's not true. Stephanie, how can you tell there's a good egg in a follicle? You cannot. You cannot. Rosin, what are the cause of fluid in the uterus and how to treat it if antihistamine protocol failed? Well, I would consider things like PRP washes. You need to get that uterus back to its normal physiology, because the normal physiology, you should be able to, you should be able to get that to be excreted. These wings, has any of these procedures been proven successful in women over 45? What procedures are you talking about? The sewing Scorpio. Oh, I see. The sewing Scorpio. Got it. Stephanie Roca. Okay. God's Grace Rochelle. I had an HSG in May. The right tube was open. Left tube lost due to surgery. I had another one in July, and the dye did not go through. What could cause this? Spasm is one, or just simply scar tissue is another. At what size does an ovarian cyst become a concern? Usually over persistently over 20 millimeters to 25 millimeters. And then from a functional standpoint, from a size standpoint, It's very much a concern of the 10 cyst. Probably a 10-centimeter cyst would be very worrisome. Is the doctor able to determine the type of blockage and the severity of blockage via an HSG? The severity likely. If it's proximal or close to the uterus, then you can't fix it. If it's distal, the end near the end of the fallopian tube, you may be able to help. If I have fibroids and do an IVF embryo transfer, how successful will it be? It's based on your age, not your fibroids. It's based on your history, not your fibroids. Hello, is there any other type of treatment for hydrosalpinx except salpingectomy? Well, a hydrosalpinx is fluid on the fallopian tube, and I showed you a picture of that before. And if you're doing IVF, you don't want that fluid to spill back inside the uterus, so you can either take the fallopian tube out, this is salpingectomy, or you can clamp at the proximal to the uterus side so that the fluid can't get into the uterus. So you don't have to do the surgery. It's a surgical procedure, but it's a small one. If someone treated with cisplatin in the past has one ovary removed, normal uterus, what are the chances of IVF? Well, Yasmin, the easiest way to determine that is by getting what's called an AMH level, anti-Mullerian hormone level. We do it at our offices. And that'll tell you your ovarian reserve. You can also, any doctor can order that for you. Rosin, 42, always had leading follicle. I tried priming with estrogen and progesterone, but my hormone levels were very high, plus I developed a cyst. What to do regarding the leading follicles? Well, Rosin, it depends on how old you are. Sometimes those leading follicles you just have to get one egg at a time. All right. You're welcome, Joanna. Lakila, if you have one blocked tube, is there a chance that an implanted embryo can backtrack? Yes. And you can get an ectopic. Yes. Very small, but true. Andrea, do you recommend the antihistamine protocol for egg retrieval? My goal in reducing inflammation and allergens is mostly for transfers, is the way I think about it, but we do recommend it for both the retrieval and the transfer. Yasmin, my pleasure. Has the hysteroscopy resulted in a successful pregnancy in women over 45? Hysteroscopy is not a fertility treatment, the sewing Scorpio. That's not a fertility treatment. That's not IVF. That's just diagnostic. If both tubes are blocked, is IVF the best option? Absolutely. Any information on reciprocal IVF for lesbian couples? Absolutely. We do them every day, pretty much at CNY. So contact the donor. Well, just become patients. We'll be happy to kind of walk through that with you. Does PRP clear the uterine fluid completely? Does it recur? No idea, Rosin. It's just I do not know whether or not PRP will remove that, but a lot of times the reason folks have uterine fluid is something is going on with the uterus itself and the secretions within the uterus, and you need regrowth. Now, logically, it would be nice if we had stem cell therapy, but only that's available in France and a couple of Israel and a couple other places. We can't do that here yet in the United States. Give stem cell therapy to the uterus, but PRP is a growth factor, so I think it's logical. Okay. Let's see. So we talked about hysteroscopy. We talked about the thyroid. We talked about adnexal torsion. We talked about thyroids during pregnancy. All righty. Miriam, I have endometriosis and adenomyosis with 3 failed IUI. Periods have been painful, worse after treatment. Would you recommend IVF next? I'm 39 and feel like I'm running out of chances. Absolutely, Miriam. But also you may want to get 2 or 3 months, depending on your AMH, 2 or 3 months of suppression prior to getting a transfer, okay? Do we choose can you choose the sex of the baby if you're doing IVF? Yes. If you do IVF with genetic testing, pre-implantation genetic testing for aneuploidy. You'll find out if they're boys or girls, and you choose what you would like to put in. Andrea, I'm trying to bank embryos over 40. Do you recommend LDN before egg retrieval? I do not. I don't have a recommendation one way or the other for low dose naltrexone. I don't have a sense of the studies on that. Okay. Thirsty. I worked out before I started the lecture tonight. Okay, I got a checkbox. That's good. I think that's good. Hello, everybody. Let's see. Instagram is building. Facebook Live is still going. YouTube is still going. Got a bunch of hearts. Got a wave. All right. Rosin, I used Gonalef with HCG/LH, got 2 frozen fertilized eggs. Again, I used Gonalef and Menopur twice, and twice I got 2 frozen fertilized eggs. What shall I continue with since I'm getting some outcome? The same outcome. I think that's telling you that you're going to get the same outcome. Just keep building up your egg bank. That's the key thing, is that the way the ovaries work is the way the ovaries work. That's based on your mom's X chromosome. It's not a lot to do with what we do. At what point do you recommend further testing like hysteroscopy after 2 failed transfers? 37-year-old with IBS, one embryo was a PGT normal. Well, if you haven't had your uterus evaluated within the last 6 months, you might want to get another hysteroscopy. You may even want to do an ERA, an endometrial receptivity assay. That's another thing that you can do. And that'll give you a better idea why that one embryo didn't stick, especially the chromosomally normal one. You want to do acupuncture. You want to do the low-carb way of eating. These are things you can definitely do and consider. Okay. Slow questions today. Usually they're so fast I can't keep up. Anybody have any questions? Dear audience. Hello, Doc. How do I feel about Omnitrope? I see it's added to my next retrieval in replace of letrozole plus Prograf and much, much more. So Shah Hussein, I like Omnitrope because it's a growth hormone, which has been shown to impact IVF outcomes positively. Razin, shall I continue with Menopur or HCG/LH with Gonalef if getting same results all the time? It doesn't matter, whichever one you're getting results on, or maybe you could save some money on, use that one. As long as you're getting the results, continue with what you're doing. There isn't any magic to the IVF process. It's just feed the ovaries with food, which is FSH, get them to grow, take them out. Which one, to Sandra, Clomid or letrozole is better? I think that letrozole is better, mainly because it has fewer side effects. It doesn't cause thinning of the uterine lining. It doesn't cause visual disturbances. And you don't need to take a break from letrozole for it to work, whereas with clomiphene, you kind of take a break after every 3 cycles. Magdalena, do you recommend the assisted hatching process? Well, we do it on all of our cases. We think it might help energetically. How do you do the genetic testing for embryos? Does the clinic do that? Do you have to tell them after the egg retrieval? No. If you guys, this is great. If you guys, okay, how do I say this? It is critical weeks and weeks and weeks before you do your retrieval that you know whether or not you want to get your genetic testing. And you need to talk to a doctor, get it on it as a procedure. There's forms to be filled out, and they must be filled out or else we can't do the genetic testing. If you need a gene tested, that may take 2 to 3 months of preparation. That's PGTM. And so in those cases, especially, you need to tell us. Yeah. Crazy love. I'm getting the HSG done. Do I also have to get the sonohistogram also? Well, it's interesting. Every one of them have its pros and cons. If you know you're doing IVF, I kind of like the diagnostic hysteroscopy more than anything else for IVF. For For IUI, either, well, I like the HSG. It's very simple, and we have one in our office, so it makes it even simpler and quicker for the patients. What is PRP and what are the benefits? Well, PRP is platelet-rich plasma, and the benefits is that it growth factors. Do you do PGTM testing for BRCA1 gene? Yes. Oh, no. At all of the places that I know, you get the sample is sent to a lab. We don't have the labs. Labs cost, the instrumentation is about $250,000, so usually we send it off. Does CNY accept? I would have no idea. Lindsay, anything about financial, please, this is not the forum. Contact our financial group, and they would be happy to talk to you about that. Rosin, do you recommend transferring 1 or 2 untested embryos at a time? I recommend 1. Melvin, it was nice to meet you today, too. Thank you for coming and saying hi, and I hope you had a good day. But thanks for saying hello tonight. I appreciate that. When you guys see me, man, come say hi and say, hey, listen, I saw you on Facebook Live or YouTube or Instagram. Can I get all the blood work done before my consultation? Yes. If you download the new family building guide, it has all the tests that are needed. You can get your OBGYN to do the testing for you. You can have all those tests. Make sure you have a copy. Make sure you PDF the copy to us. Make sure we have the copy before you see us on the first visit, and that would help a lot. Eandre, is PGTM recommended for a female who is a carrier of Fragile X? No, I'm not sure that's helpful. I think PGTA would be helpful, but I'm not the geneticist. I would call up Cooper Genomics. Okay. Hey there, Dr. Mags. Always a whippersnapper. Erica. I'm definitely a whippersnapper. I guess I'm a whippersnapper. Karen, if you have low sperm, do you suggest Zymots? No, that's not the role of the Zymot test. I'm still investigating, folks. I promise you I'll tell you when I'm done the efficacy of Zymot. What is most likely to cause a drop-off between fertilization and day 5? Is it an egg quality issue or sperm? Well, I mean, you have good fertilization, but poor blastocyst formation, likely egg. Lakila, I'm about to make 41. How many untested embryos should I implant at one time? All labs were good with the exception of my blood sugar a little high. Well, you could do 2 untested if you're above 40, typically. Now, if they're tested, you should do just 1. But if they're untested, do 2 if you're above 40. But just remember, I've transferred 1 embryo and gotten 3 babies, and I've heard stories, people transferring 2 and getting 8 babies, so not a good idea. So what is NHS? It says, do NHS help for second baby? I'm not sure what NHS is, sorry. So, Kat, the question about drop-off, it's for every 10 eggs in a 20-year-old, we expect 1 or 2 day 5 embryos. For every 20 eggs in a 30-year-old, we expect 2, possibly 3 day 5 embryos. For every 30 eggs in a 40-year-old, we expect 2. So the number of eggs is because it's harder and harder to find a normal one. One of the genetic testing, the spinal one came back positive. How would I know if I'm a carrier? Well, that's what it's saying, is that you're a carrier, right? I read it back up. Well, the geneticist should be able to tell you. Okay. How often do you see one embryo split? Often. I wish I'm one of the women to I wish I'm one of the women to transfer 1 and get 3 or more. I love big families. Okay. What causes an embryo to split? It's because it's being cultured, I believe, in a non-natural environment, and we don't know exactly why they split, but it's likely just a stress of the environment, or could be mechanical. It's very hard to say. I don't think it's the medication at all that's causing an embryo to split, but it is something we see. Is PGTM recommended for a female who is a carrier of Fragile X? I think somebody asked that already, or is that an old one? Oh, wow, these are old. I apologize. Can I get a list of medications from the website? Yep, you can. It's on the Family Building Guide. Righty. Fabiana, welcome. Jasmine, welcome. Do you ever suggest Omnitrope for women over 40 for egg quality? Yes. It's the only adjuvant or add-on for IVF that's been studied by the Cochrane Review and by others in meta-analyses to show that it improves reproductive outcomes, which means more take-home babies in my books. So, yeah, I do, especially if there's any evidence of low ovarian reserve or poor issues. Amber, my dear. Hi, Dr. Maggs. I hope you and all your team have an amazing Thanksgiving. Thank you. I'm the doc in the box for Thanksgiving, so I'll be on Thursday, Friday, Saturday. Dr. Fink is going to do some exploring in Denver, of a lovely state, with his lovely family. And I hope you, Amber, have a wonderful Thanksgiving. I'm really excited. I think there's lots to be thankful for. I'm thankful every day that I get to help you folks. It's amazing. What is the purpose of taking LDN after retrieval? My protocol is to keep taking it up until my FET. Low dose naltrexone, kind of an anti-inflammatory substance. Dr. Kiltz's Family Building Guide describes it. It's not something I particularly know a lot about. I think it's an adjuvant. It's something that might help, but there are not a lot of studies, or any studies that I know of, that say it's going to make a difference. But theoretically is what we're dealing with, because we really can't do the research on pregnant ladies. How long does it take for an embryo to implant? Usually it's around 24 to 48 hours after you place it inside the uterus. Cat, yesterday I had my retrieval. My cervix needed to be dilated, and I had a DNC. I won't get a period anytime soon because my lining is so thin. I want to do a retrieval again soon. Yes, you can do an IVF cycle without getting a period, because as long as you're not going to do a fresh transfer. If you're going to do a fresh transfer, then you have to get a period or a thin lining. Rosin, do you recommend transferring 2.9 and 2.6 together, or one fair grade with one good grade? I don't have a sense of that at all, Rosin. I'm not a grading person in terms of the data on that. If the 2.6 is better than a 2.9, or a 3.8, it just seems a little hard for me to understand. Do you utilize Lupron for priming endometriosis before stims, or what is the best primer? No, that is not a priming. It's a suppression, Lupron suppression. It knocks down the endometriosis. And yeah, if you've had troubles with it and you've had surgery recently, you might want to be on it for 2 or 3 months. Other than taking methylfolate, is there anything else I should do with the MTHFR? Not that I can think of. Not that I can think of. I received a positive blood test 5 days after embryo transfer. Is this a good positive or the HCG wash? Why would you get a test 5 days after the transfer? It's 10 days for pregnancy hormone minimum. 15 is better. It might be too soon. I don't know why you're getting it tested that soon. DG, hi, Dr. M. I'm having a robotic myomectomy in January. Research shows higher pregnancy rates for women who have a second look procedure. Would you recommend coming into CNY for some procedure like a hysteroscope after surgery? No, ask them to do the hysteroscopy while you're in there, DG. Describe Neupogen use, please. Can't, don't prescribe it. I'm working on trying to understand it, but it's not something that I can readily, Erica, give you an answer for. And since I'm not ready to give an answer, I won't. Adelaide, how do you know if, but Dr. Kills has written a lot about it, and certainly you can look it up. Adelaide, how do you know if it was just spotting or my period after a lap? Was only a few days in lighter flow. Just Go to the clinic, look for the lining. If it's thin, then that was your period. How long do I have to wait for embryo adoption, Fabiana? I don't know. You'd have to ask the donor team. I don't know. Christy, I just did my laparoscopy and hysteroscopy yesterday. How long before can I transfer? I'd say 4 to 6 weeks you can transfer after that. Rosin, do you agree with 150 Gonalef and 300 Menopur for a 42-year-old? I think that's a very smart protocol there, my dear. I think it's a very smart protocol. I am going to work let me just say this. Let's stop and breathe and be thankful. I'm thankful for all of you. I'm thankful for my staff. I'm thankful for my lovely wife, my family, my mom. I'm thankful for the many acupuncturists I've worked with and taught. I'm thankful for the amazing doctors that I share my thoughts and ideas with. I'm grateful to Dr. Kiltz for creating such an amazing organization. I'm thankful to Randy Fink, my doc here in Colorado, for sharing my days and asking amazing questions and having such a great sense of humor. My nurses, they're amazing. My MAs are amazing. My front desk is amazing. Adrian, she's the person who keeps the whole place together, and I really appreciate her, and I want to tell her a big shout out to her. My lovely wife, who's Dr. Diane Credenda from East Winds Acupuncture, she's an amazing athlete, an amazing wife, amazing mom, an amazing grandmom, but she's just an amazing doctor. She's and partner. I'm thankful for all your questions because they really, really help me understand my medicine. I'm excited about my medicine thanks to your questions. I think, okay, Christy, I love Dr. Fink and all the nurses there. Your whole team is amazing. Well, what am I, chopped liver? Just kidding. Just kidding. So I want you to be thinking about what to be thankful for in your families, in your lives. Yes, infertility is a challenge, but there's so much to life. We have tools, we're going to help you. We have techniques, we're going to help you. And sometimes we just have faith, and that's what can help you. We do walk the walk and talk the talk when it comes to creating fertility care for the masses. This is what we wanted to do. We're working night and day to do that. And it's really important to us for you to have access to care. Really be helpful to us if you learn more. And that's why we have the Family Building Guide. So I have probably hundreds, if not thousands of lectures already recorded. And I think we do 8 to 10 a week, and that's 50 weeks, 52 weeks a year. So next week, I'm going to be doing a Q&A. Karen, I'm looking forward to meet you too, Reek. And Christy, thank you. I'm just, she said, you are the leader. So of course you are the best. Well, thank you very much. I have to work on it, believe it or not, every day. I'm not sure I'm the best. But again, be safe this holiday, be prudent, eat protein. I know you're going to eat some carbs. I'm going to eat some carbs. Get good fatty foods before you eat your carbs. Don't overindulge with alcohol. You shouldn't really be drinking alcohol anyway, but don't overindulge. Don't drink and drive. If you haven't gotten your COVID vaccine, man, grab that vaccine. Grab the booster. I'm getting my booster on Friday. Diane and I are going to get our boosters on Friday. My 92-year-old mom got her booster a couple of days. She felt punky, but now she's feeling great. So anyway, thank you all. I'm very grateful. I'm looking forward to the years ahead. And I hope that you just share the word with everyone about our desire to help and your desire to get a baby. So anyway, happy Thanksgiving. Be well, be safe. Do the best you can, and we'll do our best. And if there's any time you have a question or concern, please come and speak with me. Happy Thanksgiving, everybody. You guys take